Hi everyone, welcome and thank you for attending this month's webinar. It's presented by Dr. Noreen Coleman on using simulation to design hospitals of the future. I'm Elaine Ng, one of the co-chairs of the Education Committee for IPSS, and I'll be moderating this webinar. For those of you who are not IPSS members, please consider joining the society as we offer many benefits to our members, including exclusive access to this recorded webinar and presentation after today's live session. So you can visit our website to see the benefits of membership. So a few quick housekeeping notes before we get to today's presentation. So feel free to post questions during the session. In the upper right side of your computer screen, you see a control panel. In the lower portion of that panel, you can type in a question or comment and submit it to the webinar organizers. You can do this anytime during the presentation, and we'll reserve about 10 minutes at the end for Q&A. So as I mentioned, Dr. Coleman will be discussing the use of simulation to design hospitals of the future. The session will conclude with an open Q&A period. So a bit about our presenter. Noreen Coleman is a pediatric critical care physician at Children's Healthcare of Atlanta. Her research focuses on delivery of quality and patient safety focused simulation. She's got a tremendous amount of experience in leading system-wide initiatives where simulation has been used as a vehicle to meet system-wide quality goals. She's very passionate about the role of simulation as a means to proactively identify latent safety threats in new healthcare design. So, best combination, she's got a strong clinical background, simulation expertise, and patient safety experience, and so that allows her to impact patient care in multiple facets. So Nora, over to you, and you can start your presentation.
Okay, great. Sorry, I'm just trying to get rid of this. Having technical difficulties. Let's see. Computer here. Okay. So thank you so much for inviting me to present today at this webinar, and thank you guys, everyone who has joined in to listen. So today I'll be talking about the role of simulation in designing hospitals for the future. So today I'm going to talk about some background and framework, the rationale behind conducting simulation and the evaluation of architectural design. I'll be talking about simulation-based hospital design testing, which is a process that we have used here at Children's Healthcare of Atlanta as we have begun to design a new freestanding children's hospital. I'll talk about the methodology that we use and why it's unique, and some of the implications and findings from our project. So this quote is something that really anchors the work that we've been doing here at the Simulation Center in Atlanta. In medicine, we work in extremely high-risk areas, and we'll never really be able to reduce risk down to zero. In fact, despite all the advances in hospital design and quality and safety initiatives, healthcare errors really continue to be one of the leading cause of patient deaths. So the question really is, how can we better manage risk? And today I'll really be focusing on how optimization of the built environment can lead to more efficient and safer care for both our patients and for our staff. In the past several years, there's been a major boom in the rates of hospital construction, and that is certainly no different here in Atlanta. So we recently opened a new outpatient pediatric referral center, and we are in the process, as you can see from this construction picture, we're getting ready to build our new children's hospital, which is going to open in 2025. Annual investments in healthcare construction are around $40 billion a year, and by 2022, they're expected to rise to almost $50 billion. As a result, healthcare systems are really being urged by the Institute of Medicine to build safer, more efficient facilities, but there really is no standard way to evaluate a new environment or a proposed design for safety, and that's what we're going to be focusing on today. Healthcare is complex, and we call it a complex adaptive system. And that really means that each component of the system interacts and connects with each other in ways that are unpredictable and even unplanned. We used to think of healthcare more as in terms of a linear relationship, similar to a machine. And the thought was if you took all the machine apart and just analyzed its parts, you would have a better understanding of how the whole system worked together. But this approach is a simple cause and effect assumption. And healthcare systems are much more complex and they remain unpredictable, and they can't really be described by simply breaking down parts into single components, thinking that we'll understand the whole process. So this theory really anchors the idea that elements in the system are affected by and affect several other systems because each element is constantly adapting. So small changes can have large effects. If you've ever gone through any changes in your hospital system, even small changes like Epic upgrades can have major downstream effects, or even simple changes. We, for example, just changed the monitor arms in our ICU, and it had a big downstream effect in terms of positioning and being able to resuscitate patients and see the monitors. So a little change had a big impact. The SEIPS 2.0 model is really a framework that anchors this simulation hospital design testing. It characterizes systems interactions to identify system flaws and opportunities for improvement. So the framework describes 5 components of the work system: person, organization, tools and technologies, tasks, and environment. The work system affects how care is provided, which is process, and that in turn affects how care is delivered, which is outcomes. This framework really exemplifies that each element of the work system has to be designed well so that the entire work system really functions at a higher quality. And any failure in any component has the potential to impact outcomes. So often in medicine, we are really retroactive and we are not very proactive. So we typically start with an error occurring or an issue in the quality and safety of care delivery, and then typically we'll go backwards and do something like an RCA and end up looking a lot at process. And maybe sometimes we make our way all the way back to elements of the work system. And often when we do get back to looking at and analyzing the work system, we tend to focus on people, skills and knowledge of individuals, maybe sometimes technology. We rarely look at the built environment as a means to impact outcomes, especially when we're doing root cause analysis or evaluating an error in an already existing environment. And that's because retrofitting or making major modifications to the space that we work is really cost prohibitive. So we tend to focus on the other elements of the work system. But when you're designing a new hospital, we have the rare opportunity to put an extensive focus on the built environment and make modifications that can have a great impact on healthcare outcomes if they're done early enough on in the design process. So this is a modification of the Reason Swiss cheese model. So when a latent condition in design combines with an error-provoking condition, an active failure happens, and that's when an accident occurs. So I'm going to be talking a lot about latent conditions in design as I go through this talk today. So certain latent conditions may be something like lack of standardization or suboptimal adjacency layout, inadequate space, environmental obstacles. If that combines with something like staff fatigue, poor communication, or if the environment is prone to a lot of interruptions and distractions, an active failure may result. So that might be an unsafe practice, a workaround that violates procedural standards of care. It may create delays in care that impact patients or may cause workflow inefficiencies. Next, I'm going to move into the role of simulation and kind of the rationale for why simulation has a role in evaluating architectural design. So why conduct simulation? And this is a question as we've gone around talking about our project and have been working to publish some of the work that we've done. We get this question very often. Why conduct simulation and spend all of this time and resources doing this work? And the answer is to evaluate for these latent conditions in these design features at a point where major modifications are feasible and cost effective. And as we go through this section of the PowerPoint, I'm going to talk a little bit about more but the rationale behind why we can't just sit around at a table, look at drawings and kind of make the best decisions. It's really important to engage hospital executive leadership and the hospital design planning committee. They really need to support the project in order for this kind of initiative to be successful. Early engagement in the architect and design team is really unique and necessary for this type of work, because the architect team needs to be engaged in the simulation process. They really need to come to simulations and watch the end users interact with the space. They need to be open to hearing suggestions in order to make design modifications that are going to improve the proposed design. And then lastly, it's really important to have clinical leaders and frontline staff. And the frontline staff is essential to this type of work because they're the people that are delivering care on the front lines. They really understand care process, and they're most equipped to give useful feedback. And then testing has to occur during design development. And I'll talk a little bit about the timeline for testing as we go through the presentation, but it can occur during schematic design and detailed design development. And I will define those in a little bit. And it has to also take place with enough time for the architects to make design modifications prior to finalization of design drawings. And I just want to point out that this process can really be applied to any institution with any kind of organizational culture. Is going to be different anywhere you go. So this process is modifiable and can be adaptable to the needs of the institution. It can be applied to small projects, small renovations, small construction, and then large scale projects such as the one that we embarked on. So in the planning of a new healthcare facility, it's an evaluation of the work system. There's a practical need to imagine how work will be performed in the space. And that is known or called as work is imagined. Work is done, on the other hand, reflects actual delivery of care and realities of the work system. So as Eric Hallnagel describes it, it is impossible in practice as well as in principle precisely to prescribe how work is done. And so if you can think about a time where you have created a new process or something has been modified in your hospital and you tried to implement a new process and then teams didn't actually work with the process or implement the process as you anticipated, whether it was a lack of knowledge or unclear guidelines or the resources were not available. And in designing a new healthcare system, it's impossible to imagine all of the complexity of care and all of the possibilities that may result. So we've been asked, how come human factors specialists and system engineers can't look at a blueprint of a floor plan and make the right decisions? And that's because these methodologies are actually challenged by the notion that they are dependent on work as imagined and really don't incorporate work as being done. So this is a picture of our mock-up for one of our ICU rooms. And in the very, very early phases of design planning, when we were deciding on how big the room should be, they put tape out on the floor, and this happened before we were able to do the cardboard construction mock-up, but they put tape on a floor, brought a bed in, an oscillator, equipment, nursing equipment, poles, and said, okay, everything fits. So this space and this size should work well. So that is work as imagined. And then what we realized as we conducted simulation was that that did not equate to work as being done. So as you can see, this is what we call patient elevation. So this got probably my most hits on views on Twitter when I posted this video. But this is a patient that needed to be cannulated onto ECMO. And so in order to cannulate this patient, the team needed to switch out this white crib into an ECMO crib. And because of the limitations in space and with the patient already being attached to the ventilator and to IV poles, the team literally put the kit on a backboard to lift the patient up, to move the bed out and put another ECMO bed in. So probably not what anybody imagined would happen when this team came in to put this patient on ECMO, but certainly this was a workaround that the team had to create because of the limitations that were in the physical environment. So during early design planning, architects have to be able to convey design intent and elicit specific information from clinicians to make design decisions. On the other side, clinicians really have a great understanding of care processes, but while architects speak structural need, building codes, regulation, and they really understand the built environment, clinicians are going to focus on care processes. So the challenge to collaboration is that architects and clinicians really speak two different languages, and they look at design through two very different lenses. When I started to do this project, looking at architectural drawings was like reading a different language to me. We had to like flip the papers around, trying to decide like what angles we were looking at, where we were in the space. And so it's really hard for clinicians to take a two-dimensional drawing and imagine how big the space is going to be or what that space is going to look like, and imagine how care will be conducted. At the same time, architects don't necessarily have all of the understanding of the complexities of care delivery, and sometimes have never seen care being conducted in the space in which they are designing. We'll talk about that a little bit more. So simulation really helps level the perception between work as imagined by architects and work as done by clinicians. So we're going to talk a little bit about simulation-based hospital design testing and get into the methodology and some of the impact. So simulation in a full-scale cardboard mock-up provides really a shared experience for both clinical end users and architects. This allows clinicians to interact with their environment. It provides the architect team with feedback, evaluates the impact of design decisions, and can be used to also test design alternatives. It can be applied to test functionality and limitations of the environment for both routine care and infrequent and high-risk clinical scenarios. And like I mentioned before, it also provides the architect team with insight into clinical processes that they would not otherwise be able to observe. And because healthcare is so varied and care is very dependent on organizational culture and individual practices, architects have it's hard for architects who have to modify the design to fit individual end user needs. So it's not, architectural design can't be cut and paste. What works at one hospital may not work at another hospital, but it's hard for architects to elicit those cultural differences and those variations in care practices in order to create a design that best meets end user needs. And that's where simulation really helps to bridge that gap between the architects and the clinical end users. So simulation-based hospital design testing included creation of clinical scenarios that represented routine and high-risk cases. We then did debriefing in order to conduct a risk assessment and applied failure mode and effect analysis to categorize and prioritize safety threats. Findings were then reviewed by our design team. They made modifications to the design alternatives or gave the teams different options in order to address safety concerns that were brought up during simulation. The changes were actually then made to the mock-up, and then the teams came back and re-simulated the same clinical cases with the design modifications represented in order to validate those design changes. What you'll see in typical exercises during design development might be tabletop exercises or simple mock-ups. So the first top picture is a picture of what they call paper doll exercises. And this is where models are used to imagine space and kind of imagine workflows. And this is applied really early in the stages of design planning. So the limitation is that this is very abstract, and it really asks end users to imagine what care and what space would look like. So it has the ability to convey design intent is pretty limited. The bottom picture is a simple mock-up, which is great to convey spatial layout. And sometimes this simple mock-up may get confused with or be called simulation, but it doesn't actually involve doing and walking through care processes. So teams might walk through the space to kind of get a sense of how big the space is, the square footage, but they also are required to imagine, again, how care would be conducted. And so simple mock-up do not truly reflect the complexity of care delivery. Virtual reality is another methodology that is used in hospital design. And this is good to also convey spatial layout and orientation of adjacency or areas. I was able to do some virtual reality and kind of look at different boom vendors and really get a sense of space and how the booms would be planted in the rooms and move around. But you only typically in virtual reality, you only get to see the space through one avatar or one sight line, and you don't get to interact with other people. And it's kind of limited in the ability to interact with equipment and kind of move patients through the space. So high fidelity simulations is what I'm talking about today, obviously, and that really asks end users to conduct care activities and better represents the complexities of patient care. Obviously, this is much more time and resource intensive than virtual reality or even simple mock-ups. So there's two phases, as I mentioned before, to design development, and I'll kind of be using this terms as we go through the results of our simulation design testing. So schematic design really is looking at layout and adjacencies, orientation of the space, and configuration. So when we talk about schematic design, we're looking at how is the care team station laid out? Where is the medication room? Where's the equipment rooms? How do people and equipment move through the space? When we're looking at detail design, that's where you're really getting inside the patient room or the care area. And you're looking at the room layout itself. How is the bed situated? How are the booms mounted? And you're looking a lot at mounted equipment. So if you can see the picture at the bottom right-hand side, you're looking at where are your medical gases? How are they oriented? How close are they to the bed? Where is your suction? Is the suction above outlets or underneath outlets? Is there any environmental fire hazards? Can teams reach the equipment in a case of an emergency? So we had a lot of discussion about where our code blue buttons were going to go and whether they were accessible to people managing the airway or if they needed to be accessible to people moving in and out of the room. And we'll talk a little bit more about some of the things that we found related to these phases of design planning. So hospital design and construction can be up to at least a 7-year process, if not more than that. And simulation and design development is really going to take place in the first 1 to 2 years of design planning before construction begins. So it's really important to engage hospital stakeholders and the architect team in this idea of conducting simulations really early on in the design process, even as early as doing program validation. And that's because simulation has to be embedded into the design planning timeline so that teams can make some design decisions and have a design prototype to test. And then there needs to be enough time after simulation for the design team to make modifications. And if there's the time to conduct a second round of testing, they also need additional time to do that second round of testing and make potentially more design decisions after that second round. And all of simulation has to be completed prior to finalization of design plans. So in our timeline, they actually had to push back some finalization of design plans because they were still making iterative changes to the detailed design following round 2 of simulation. And so they actually needed an extra few weeks to finalize their drawings before handing it over to the construction team. So we often get the question of, can you squish simulation and shorten the timeline? And you really can't, because you need to have enough meetings to start with a prototype to then test in simulation with enough time following simulation testing. So a lot of people ask us, how do we demonstrate return on investment? So as you can see in the circled areas there, design development, detailed design development, and schematic design development occur at a time where you can proactively improve the design. If you are looking to modify the design following construction, it becomes extremely expensive due to the cost of retrofitting. So of course, it's much easier to move walls in cardboard than it is to move in concrete. And so doing simulation early in the design process can actually save costs and is more cost effective in the life cycle of the project. I'm going to get into some debriefing, the methodology we use, and talk a little bit about debriefing and failure mode effect analysis. So just before we get into that, just a little overview of what our team looked like. So we actually had a fairly small team. We had a project leader, which was myself, and the project manager. And then we had a core simulation team. So our core team was actually pulled to do this project. And the way our simulation center is designed is that we have simulation-based educators that are department-based. And so educational simulations were able to occur simultaneously to this project. And we really pulled the core team from other initiatives to focus on this work. So we had two facilitators that one focused on the diagnostic and treatment areas, and those included the operative areas, the emergency department. Another facilitator focused on the bed units. They did attend all of the design meetings, and the reason for that is to understand what the architect team was trying to elicit, what information they needed to elicit from the end users, what were some questions that we might need to address in simulation and answer. So they spent a lot of time attending all of the meetings. They helped to build content and then confirm participants and help stage and prep the mock-up. We had one of our team members be the head of organizing all the equipment and supplies, because we did have to procure quite a lot of equipment to basically simulate an entire hospital. And then we actually had two part-time simulation technicians that were responsible for programming all of the scenarios, helping also to obtain and organize equipment and supplies, and then prep the warehouse and prep the scenarios in between all the scenarios during testing itself. What's unique to the methodology and strategy we used with our simulation testing is that we integrated 3 methodologies. I'm going to talk a little bit about evidence-based design and what evidence-based design principles are. And then, of course, we use simulation and debriefing. And then we integrated failure mode effect analysis, which is a quality improvement tool. And integrating these methodologies allowed us to identify latent conditions that are known to impact outcomes, identify a wide range of latent conditions, and then really helped us to prioritize findings so that the architects could focus in on addressing latent conditions or threats with the highest risk to patient safety. So evidence-based design, sorry, I got a warning message. So evidence-based design is similar to the evidence-based medicine that we use in healthcare. And so evidence-based design is driven by rigorous research that links the physical environment to healthcare outcomes. So when architects are designing a space, they're looking at what kind of air filtration system is being used to minimize cross-contamination and prevent infections, maybe what kind of materials are being used in the environment to make sure there's things that are not porous that minimize cross-contamination or infection risk. They look at things like noise, especially that's really important in places like the NICU for development, sleep, access to light to improve delirium. So we actually applied these evidence-based design principles and really use them to anchor our testing objectives. And these principles are described by HRQ and the Center for Healthcare Design, and it really expands on that SEIPS definition of the environmental system. So the idea is if these principles are not effectively incorporated during design planning, there will be errors in design, and this will generate a latent condition like we talked about in the Swiss cheese model. So the AHRQ and Center for Health Design evidence-based design principles are really intended for the post-constructed environment. And so what we did was work through the materials that were available to us and modified these principles to apply to the pre-constructed environment. In a post-constructed environment, in a pre-constructed environment, it's really hard to assess, of course, noise and lighting when you're in a warehouse. So we had to make those modifications to be applicable to what we could evaluate in cardboard. And then once we get into the post-constructed environment, we'll be able to test some of those other evidence-based safe design principles. So just to summarize our methodology, we used 2 rounds of testing. So in round 1, teams came and they performed routine and high-risk clinical scenarios. We conducted debriefing and FMEA to categorize and prioritize latent conditions. The architects then used the simulation findings to make design modifications. The design changes were reflected in the full-scale mock-up, and the same teams, as much as we could get the same frontline staff back to the warehouse, they returned and they performed the same simulated scenarios with the design modifications represented in cardboard, and we were able to retest and validate those design alternatives. And in debriefing for round 2, the teams identified any additional latent conditions or any downstream effects from any design modifications that were made. So the thing that makes doing this pre-construction design simulation testing much different than what you would see in education-based simulations or even process testing is that the facilitation has to be very heavily focused. So if you send a team into a cardboard space, they're not familiar with the space and they are not really going to know what you want from them. So it's really important that all of the objectives for testing are identified ahead of time, and that facilitation is very heavily, simulations is very heavily focused. So we conducted simulations almost more like a movie director than an educational simulation. So teams weren't really making a lot of medical decisions because we wanted to ensure that they were going to interact with design features that we wanted to test. So the teams were really directed to interact with certain rooms, certain spaces that were included in the mock-up. So this is one of our facilitator guides. As you can see all the way on the right-hand side, those are all of the evidence-based design principles. So we were looking at location. This is for detailed design phase. So we were looking at where the medical gas is, how many medical gases are there, how did they use the mobile documentation stations, how did they use the nurse server, were they able to perform procedures and move around the patient. So we really took away medical decision-making and told the teams, okay, you're going to admit the patient. These are all of the areas that you need to go visit. So to admit a patient, the teams needed to go to clean supply and get linens. They needed to go to the equipment room and gather nursing IV poles. They needed to go to respiratory equipment room and gather respiratory supplies. And so we were really able to make sure that the teams interacted with the design features in question. So here again is the anchoring safe design principles. And these are some potential latent conditions that we tried to elicit during debriefing. So were there inefficiencies in layout? Did the layout support teamwork and communication? Could you actually get to your supplies in the case of emergency? Was the environment adaptable to your varying patient care needs? And then we elicited whatever potential active failures may result. So was there a procedural violation? Was there a delay in care? So for example, in our initial design, our respiratory equipment room in the ICUs, it was only accessible from one side of the hallway. So in a patient emergency, when the patient was decompensating, we had the team first get a regular ventilator. And then we had the patient become more hypoxic, so they needed an oscillator. And so they recognized that in order to get to the equipment room, there was excessive walking because they had to go all the way down the hallway and to the other side of the hallway. They also recognized that the room itself wasn't big enough and they felt like they would have a hard time getting equipment. So the combination of excessive walking and not being able to have enough space to store equipment would cause delays in care, or even create equipment damage if they were having difficulty yanking equipment out of the room. So just to review, it's important to determine what design features the participants will interact with. And then you really want to detail out kind of like a process map, each step that the team is going to take to complete that care. And once the scenario is fully written, ensure that you're able to detect a wide variety of latent conditions and that you've met all of your testing goals. So we also used a unique debriefing guide. We call this SAFE, and this was different from some of the other debriefing approaches that have been suggested. And that's because we really needed to focus in on the built environment and use these safe design principles to guide what we were eliciting from our frontline staff. And I'm not going to spend too much time on this today, but I will be talking about this debriefing guide at IPSSW, the meeting in April. So hopefully, if you're interested, you'll come see me there. Failure mode effect analysis is the proactive assessment tool that we use to categorize and prioritize the safety threats. And so we created a unique FMEA scoring rubric that we used during our FMEA scoring. So FMEA scoring was based on group consensus, and we divided the severity categories into patient safety, performance impact, employee safety, patient and family experience, and organizational priorities. And the definitions were based on things like the SSE criteria. They were based on the Joint Commission regulatory violation definitions. They were also based on our employee leave policy and our patient grievance policy, and that's how we came up with the definitions. So the teams assigned a severity category, and then they also assigned an occurrence score. So we went through each latent condition. So during the debriefing, I actually scribed all of the latent conditions identified into a pre-formatted FMEA template. And during FMEA scoring, we went through each latent condition, stated what the latent condition was and what the potential failure effect. And the potential failure was things that the team discussed during debriefing. And then the score was based on group consensus. So first, the team assigned it to a risk category, and then they assigned a severity score and an occurrence score. And those were based on a 5-point Likert scale, as you saw in the rubric on the slide before. We then calculated the criticality score, and that was multiplying severity times occurrence. So the max score was 25, and the highest risk threat was anything with a score between 20 and 25. And then we generated a report. So the top picture is our round 1 report, and the bottom picture is a round 2 report. So what we did in round 2 was we took each latent condition that was related to architectural design, linked it to the design modification that was made, and the teams actually rescored that design modification after the second round of testing. So just some findings and impact from our testing. This is our cardboard city. And this was conducted in a 100,000 square foot warehouse that was out about 15 minutes from our hospital. And the hospital rented this space for a year. And this is a video that's the sound is not actually going to play, so I'm just going to scroll through this quickly. And you can kind of see it's a great aerial shot of the warehouse, and what you're seeing here is our bed unit being constructed. And people ask us who constructed the warehouse, so I'm just gonna move on through. This is Rick. He's from Brassfield and Gorey. And so the construction team actually did all of the mock-up construction. So they received all the drawings from the architect team and then made those, translated that into the cardboard mock-up. And I'm just gonna keep scrolling. As you can see, our participants were wearing colored vests to identify them as participants. And then we had a bunch of observers watch simulations. They all had observer tools to help really anchor their observations to the design elements that we were testing. And then we debriefed after each scenario in a separate room in the warehouse. So all in all, we looked at our bed units, which included our HEMONC unit, cardiac ICU and step down, all 3 ICUs, our general care and transplant areas. And then we also evaluated cardiac, OR, cath lab, our emergency department, radiology, our surgical services areas, so OR, special procedures and day surgery, and our SCU or our Ebola unit. And here's some more pictures from the mock-up itself. So we had over 800 participants come out to simulation. We conducted 146 scenarios over 41 days of testing. And we identified a little over 500 latent conditions that were related just to architectural design. So our architects were really embedded and engaged in this, in our simulation testing. And so this is kind of just a review of all of the latent conditions identified in schematic and then in detailed design. They made hundreds of design modifications. And so in schematic design, the modifications that they made address 63% of the latent conditions identified and 64% of the latent conditions identified in detailed design. So overall, over 300 latent conditions were mitigated with design changes. The things that we weren't able to accomplish with design, most of them were pretty low risk or preference-based things. Some were limited by budget that we weren't able to change. Some things like people always want more space. And so some of the size constraints were obviously not able to be modified at the phase of design testing when the hospital size had already been established. Other latent conditions were really going to have to be addressed through future process work or addressed with technology. So we analyzed the data from our schematic design, and we demonstrated a statistically significant reduction in criticality score. So overall, the mean score dropped by about 8.5 points between round 1 and round 2. And you can see in the chart to the right-hand side that there was a statistically significant reduction in criticality scores amongst each area tested. And the amount of about 75% of the scores met high risk to very high risk severity category. And then when the scores were recalculated and rescored in round 2, only 16% of scores had a risk severity of high risk or very high risk. So just some findings in the last few minutes. I'll just describe some of the findings from simulation. So we did a lot of design around the care team spaces to better support communication and collaboration between team members, to support better visibility down the hallways. We made a lot of modifications to how clinical spaces were oriented. So we realized that spaces were not co-located in ways that made workflow efficient for staff. So we co-located things like our medication room with our clean supply room. They made the respiratory rooms bigger and made it a pass-through so it could be accessed from both sides of the hallway. And that was something that resonated through our diagnostic and treatment areas as well. In our special care unit, they needed to redesign the room so that there was unilateral flow to reduce risk of cross-contamination for those patients. They basically redesigned all of MRI and changed the angles of the doorways and access into the MRI suite so that there was improved mobility from the MRI scanner into resuscitation bays. We made a lot of changes to the emergency department. So in the initial drawings, the emergency room had malaligned corridors, and so to move patients from the patient room into the trauma bay required multiple right angle turns. And if anybody's ever dragged a patient down the hallway on a stretcher, you'll know those things are really hard to maneuver. And so minimizing those right angle turns really helped get the patient out of the exam room into the trauma bay quickly. I'm just going to move on to some of our detailed design findings. So we made some changes to the angles of the doors in the trauma bay to improve access in and out of the room. We spent a lot of time talking about where medical gases, where electrical outlets were, where the code button would go, how to access the nurse server and the angle of the nurse server. I think one of probably the biggest change that we made was once we got into the operating rooms, the teams did not like how the bed was oriented at all. So they actually decided they wanted to turn the bed 90 degrees from the way the room was designed. And that had a lot of downstream effects. So all of the air ducts needed to be moved, all of the vent systems needed to be reoriented, the booms needed to be reoriented, the documentation stations and workstations needed to be moved. So had that happened post-construction, if the teams needed to change the bed positioning, that would have cost over $1 million per OR to modify. So that was a big modification made during detailed design development. So just to summarize, When you're designing a healthcare facility, it's really impossible to imagine all of the possibilities and the complexities of care. And simulation really takes work as imagined and transforms it into work is done. And so it allows for the architect team to better understand end user needs, to identify latent conditions in design, so that we can build safer and more effective hospitals in the future. And please, reach out to me. You can find me on Twitter, LinkedIn. I'm happy to share our resources with anybody interested, and my email is here, and I will open it up to questions.
Thank you, Nora, for a super informative presentation. So I have time for questions. So you can submit questions anytime by typing in the webinar's control panel. There was a question, and this may be for our admin staff, if we can get certificates of attendance at the end. And I don't know the answer to that, so we'll park that for now. So I have a million questions, so I'll keep an eye on the question panel. So Nora, this is a gigantic project. I can't imagine doing that just from an organization that hasn't quite bought into simulation in this scale. So maybe can you describe a little bit what your hospital is like? Like how could you even make this happen? This is gigantic, not just the design of the simulation, but you have to let people out. You have to rent this gigantic warehouse space and do all this mock-up, and the architects actually listen to you from day one. It's just unimaginable. Like, so it must be something about the culture of your place, I'm thinking.
So that's a great question, and something we get asked a lot. We've spent a lot of time really demonstrating the value of simulation, but this project really took it to the next level. And the idea is, can you create something that is safe? So when you ask architect teams or hospital administrators, what are you doing to ensure that, what process are you going to take to ensure that this design allows for the safest and most efficient care? And there is no answer. There is no methodology. And there's no standard way that institutions ensure safety and really put safety at the forefront of design planning. And so I think that's how we got everybody's attention. And we aim to be publishing some return on investment to help others kind of drive the impact of simulation if they're interested in using that at their own institutions. But we were lucky enough for the system to really buy into this process. And once you get the ball rolling, teams realize the impact. So we almost can't get through anything anymore without doing simulation testing. Everybody wants to evaluate the space because there's so much that you can't anticipate and plan for. And it's so hard for stakeholders and clinicians to conceptualize and visualize space. If you think about your hospital system, how many times have you had a renovation and you get into the space and there's so many problems with it and things aren't working and it needs to be retrofitted, or an accident happens because the code blue alarms didn't work or were not accessible. And so really we were able somehow to convince them that work is imagined doesn't equate to work is done, and that this would be impactful in creating a space that was safe so that they wouldn't have to spend all of this money retrofitting unsafe design after construction.
So there is a question to say, how did you get buy-in? So I guess kind of moving on from what you just said, like, did you invite yourself to there, or they invited you? Like, how did you even get there so that you are there for the planning? Because a lot of times as clinicians, or even
so Kiran Habar, his name and information down at the bottom there, he is so Dr. Habar, he's the medical director for the Sim Center and really has a great partnership with a quality improvement team here, and really met with our CNO, who is the lead on this project, and got her buy-in to engage frontline staff in the design planning for the hospital. And so really worked with the operational team to foster buy-in, and they in turn, once the executive team was bought into it, they basically said to the architects, we're going to go ahead and do this type of testing. But the architects were really great and very open to this process.
That's incredible. So another question, what is the cost of investment in terms of time and salary for your team?
Sure. So we're still working on pulling the cost to get staff out to the warehouse, but the cost of conducting a very, very rough estimate was about $2 million to conduct this testing, but they saved much more in design modification. So just in the one example I gave for the ORs saved $1 million per OR room had that issue been identified post construction. So the return on investment we anticipate is significant, and that's what we don't have the exact numbers yet, but that's what our operational team has told us.
Great. Another question. So it says, many thanks, Nora, for a great presentation. I'm curious, was there an effort upfront to improve current workflows as part of that work imagined?
So it's really hard in this early phase of testing to focus on process and workflows. So we really focused on design, and this is doing this type of work is longitudinal. So it starts with design development and it will go through post construction. So once we get closer to the finalization and of the hospital, we'll be able to focus more on the other elements of the work system. So really hone in on process and technology and tools and tasks and education. And we will continue to do similar work to this, but really then look more towards system integration, testing and clinical process testing as a means to improve workflows. We interestingly identified a lot of inefficient workflows happening in current practice. So it was very eye-opening to do this simulation and highlight all the inefficiencies in current practice and the workarounds people have created because the environment doesn't function as well. So we did work a little bit with our quality team to provide all of the latent conditions or latent safety threats we identified that teams are actually performing in our current state. So in that sense, we did identify a lot of workflow barriers and workarounds.
Right. So, there's so many things to test. And I know you say, oh, the common and the critical. So, but how do you select them? Because there's so many things to test in so many areas.
That's a great question. So that's why we use these evidence-based design principles. So we really started there. And this has been an iterative process for us. So we have learned how to kind of refine and modify this process as we went through multiple rounds of testing. So we really start with those safe design principles and really use that to anchor what we're going to test and to help narrow our focus. So we say, okay, here's 10 safe design principles. Over 3 scenarios, we have to address all of these. We have to address standardization and visibility and access to equipment. And then we went and created the clinical context to meet those testing objectives. So we knew we had to do some routine care and some very high risk scenarios and make sure that by the end of the day we had met those 10 we had addressed those 10 safe design principles.
Okay, so not to poo-poo your work at all, because seriously, this is amazing. Is there somewhat of a script that you followed in order to do this? Like, is this like a prescribed way of testing a big center, or you had to kind of with something novel along just to address uniqueness of your center?
Sorry, you had cut out like halfway through your question. Could you repeat it?
So I hope you heard my first bit. I said not to poo-poo your work because it's amazing. Yes. But is there a script? Is there something you had to kind of reinvent and be innovative along the way? Because there really isn't a methodology to follow to test the simulation.
Yes, so I have to give credit to teams at Seattle and Texas Children's who have been doing this type of work and really doing process and systems testing, who they started this idea of the application of simulation in design and making space utilization more effective. So we have to I want to credit those pioneers in doing this type of work. And then we really took the foundation and made it iterative as we've gone along through this process. So we have now created facilitator guides and scripts and conceptual models. And like I mentioned, we have created a debriefing guide, but all of those have been iterative, and we have started with one FMEA, and we have now had multiple versions and kind of landed on one finalized version. So this has been an evolution for sure, and we have made a lot of modifications to our approach, but have really tried to create tools that can help others standardize and apply this work.
That's amazing. So the debriefing guide you mentioned, the SAFEE, that's a brand new, well, not brand new, but it's specific and new for this type of work. Yes?
Yes, it has. It's not something that's been published or discussed. There's a new debriefing guide by Dubé and her group, who has created a guide to debrief system integration testing that really applies post-construction, but nothing exists that's specifically geared to the pre-constructed mocked up environment. And that's what our debriefing tool was developed for, and we are hoping to publish that shortly.
Well, you're presenting at IPSS, so that's great. There's another question from the participants. What were the main challenges? Has this model been used internationally, or is it new and used only in the USA? Can you allow people using your model in low resource settings?
Yes, so it hasn't, from what I understand, it hasn't been used internationally, although as we have gone around to talk about our approach, people have asked us for resources, and I have reached out to some people overseas who are looking to conduct this type of work. And what was the second part of the question?
Can you allow people using your model in low resource settings?
Yes, I think this model can be adapted to tailored and adapted to any institution's needs. So we have not done this work at low resource settings, but it certainly can be modified to meet the needs. Even just thinking about how can you optimize the environment in already existing spaces. Can you do simple things like move glove boxes or reorganize workspaces? Those things can be applied to low income areas or low resource areas, and even to already existing environments.
Okay, great. And then the other part of the question was, what were the main challenges?
Oh, so I would say there's a lot of challenges. I think the first challenge is what?
You made it sound so easy.
I would say the first challenges was really for us wrapping our minds around the breadth of work that we needed to do, and ensure that there was so many moving pieces. So not only working with the architect firm and working with the construction company and our hospital executive team, kind of getting everybody on the same page to understand the goals of testing, I think is the first challenge. So if you are in an institution, you probably have never done this before. And so nobody really they bought into and gave us support to do the project, but didn't really understand what that meant. And so really we had to spend a lot of time getting everybody to understand the purpose and the intention. And so we actually met with all of the clinical stakeholders and leaders in in-person meetings, because we realized email was not an effective way to communicate. And so we sat down with all the clinical leaders individually, and it described why we needed their staff, why we needed their buy-in, and what we were going to be doing. And I think the other limitations is really, bridging that gap between the architect team and the construction team, and making sure that the mock-up was to the fidelity we needed it to be, that we got the equipment out to the warehouse that we needed. Those are some of our big challenges.
All right, thank you so much. Now I noticed the time is 12:30, and we said we'll go till 12:30. But if you have a burning question, you can still post it. So I'm going to say my last concluding remarks. So thank you all very much for participating in this webinar, and thank you again, Nora, for this very stimulating presentation. So shortly, the participants will receive an email from IPSS that includes a link to an evaluation. So please take a few minutes to access it and provide your feedback on today's session. So the recording of today's webinar, along with the handouts discussed, will be posted on the members-only part on the IPSS website in the near future. As a quick reminder, registration for IPSSW 2020 is currently open. Early bird pricing is available until March 20th. So we're also still accepting late-breaking poster submissions until March 2nd. So let us know, get in touch. The conference will be held jointly in St. Petersburg and Tampa, Florida from April 26th to 29th. We hope to see you there. And then the question certificates that Caitlin, our organizer, will get in touch with you. And whoever else needs something, let us know, and then we'll just answer your questions privately. Nora provided all her contact information, so I'm sure she'll be happy to answer your questions. All right, guys, have a good day. Thank you so much. Bye.
Thank you.